Welcome to your meeting with ICM. The interpretation button should appear at the bottom of your screen, next to the Share Screen button. By clicking on the interpretation button, you can choose the language you would like to hear. The interpretation button will then transform this meeting into the selected language. To change the language you would like to hear again, follow the previous procedure by clicking on that same button. By default, you will hear the selected language at 80% volume and the original audio at 20% volume. If you would like to mute or unmute the original audio, click on the corresponding option within the language button. Enjoy your meeting. Bienvenue à votre réunion avec l'ICM. Comme la réunion propose une interprétation simultanée en français, le bouton Interprétation devrait apparaître en bas de votre écran à côté du bouton Partager l'écran. En cliquant sur le bouton Interprétation, vous pouvez choisir la langue que vous souhaitez entendre. Le bouton Interprétation se transforme alors en la langue sélectionnée. Pour changer à nouveau la langue que vous souhaitez entendre, suivez la procédure précédente en cliquant sur le même bouton. Par défaut, vous entendrez la langue sélectionnée à 80% de volume et l'audio original à 20% de volume. Si vous souhaitez couper ou supprimer l'audio original, cliquez sur l'option correspondante dans le bouton de la langue. Bonne réunion. Bienvenido a su reunión de la ICM. Como la reunión ofrece interpretación simultánea en español, el botón Interpretación debería aparecer en la parte inferior de su pantalla, junto al botón Compartir pantalla. Haciendo clic en el botón Interpretación, puede elegir el idioma que desea escuchar. El botón Interpretación cambia entonces al idioma seleccionado. Para volver a cambiar el idioma que desea escuchar, siga el procedimiento anterior pulsando el mismo botón. Por defecto, oirás el idioma seleccionado a un 80% de volumen y el audio original a un 20%. Si quieres silenciar o desilenciar el audio original, haz clic en la opción correspondiente del botón de idioma. Disfruta de su reunión.
Welcome, everyone. You can actively engage in this session through the chat box function, and for any questions you might have, feel free to use the Q&A button in the bottom of your screen. We will address your questions at the end of this session. Now I'm going to hand over to Oliver.
Thank you so much, Brina. Good morning, good afternoon, good evening. Welcome to the last but not least session number 5 of our 5 webinar series. Today we are going to talk. Can we have the screen? Okay, thank you so much. Today we are going to talk about scaling up the midwife-led birthing centers model of care in low and middle income countries. My name is Oliver Bazirete, a midwife and the Dean of the School of Nursing and Midwifery at the University of Rwanda. I've been a member on working team of this project. Let's see what we are going to see today. After this welcome and introduction note, we will have a brief recap of earlier session. I will introduce today's speakers. They will give overview of findings, success factors, and challenges. We shall see an aspirational MLBC definition, then a pathway to change to support scaling will be presented. Then we shall have time dedicated to questions and answers. Next, please. As a brief recap of earlier sessions, our study has shown that there are diverse models of MLBCs across different countries. And MLBCs can be cost-effective regardless of sector, time, and location. Most of our case study MLBCs demonstrated better health outcome. Half did this at a low cost than standard care in that specific country. Next, please. This project generated the free resources that are available online, and you can always refer to them as necessary. The links are also pasted in the chat box. Links for recording of earlier sessions are available in English, French, and Spanish. You can also have access to published papers from this project on these links displayed here. The first one is a scoping review and a scoping survey of MLBCs in low and middle income countries and their main characteristics. The second one is about the network of care in implementing midwifery birthing centers in low and middle income countries. The third one is a case study conducted in 4 countries of the low and middle income countries. And these countries are Bangladesh, Pakistan, Uganda, and South Africa. Our 4th paper on economic analysis of midwife-led birthing center is still under review, and we hope to get it published in the next couple of months. Next. Next, please. Now, this is your feedback on the first 4 sessions. We thank you very much for your active engagement and good feedback. We will analyze it and produce a frequently asked questions document to share with you. It is clear from your feedback that you need resources and guidance to establish and strengthen midwife-led birthing centers. The World Health Organization supports midwife-led birthing centers in setting with strong midwifery programs. Global guidance coming from the World Health Organization by STAGE, and STAGE is a strategic and technical advisory group for maternal, newborn, child, adolescent health and nutrition. With regard to advocacy matters, the results of this study will play a crucial role to support advocacy. ICM will continue working in this space. An example is a piloting a facility readiness tour in Zambia and Pakistan. Next slide, please. We have a couple of objectives for today's session. The first objective is to draw together the key findings from the previous 4 sessions. The second objective is to introduce and explain 2 resources that emerged from the research and will be useful for establishing and strengthening midwife-led birthing centers. An aspirational definition of a midwife-led birthing centers that applies in all settings, and a pathway to change to support the introduction or scaling of the model of care. Next, please. There are some guidance for using the chat and Q&A boxes. Use the chat box to introduce yourself and chat to other participants. Comment on what you are hearing and share your own experience. Use the Q&A box to ask specific questions relating to the presentation. Next. Next slide, please. Allow me now to present the 3 speakers for today's session, who also play an important role on this project. We have first Kirsty Hughes, the researcher and working with Novametrics. We have Mandy Foster, the regulation advisor for International Confederation of Midwives. And we have Karen Hammer, Deputy Director of Barnett Institute, and also the technical co-lead for this project. Now I hand over to Kirsty. Thank you.
Kirsty, you're on mute.
So sorry. Thank you, Oliver. Good morning, good afternoon, good evening to everyone. My name's Kirsty Hughes, as Oliver said, and I'm a researcher with Novometrics. I was part of the research team on this project for ICM and involved in the case study analysis. So I'm just going to run through a recap of the findings of the case studies in terms of the factors for success for MLBCs in low and middle income countries, and then share with you some of the challenges which came through the research too. So sessions 2 and 3 of this webinar series covered those themes in more detail. So do listen back to those if you want to know more. But to recap, through the case studies that we carried out in the 4 countries, that is Bangladesh, Pakistan, South Africa, and Uganda, we found 4 key areas for success. So firstly, sustainable financing is essential. There is no one size fits all, but a range of financing models can be effective, including public, private, or a combination. The provision of quality midwifery care is really important and ensures that women want to use the MLBCs. Women valued midwives' competence, respectful care, and receiving interventions only when needed. Interdisciplinary and interfacility collaboration was our 3rd theme, including professional respect for midwives, a functional referral system, and trusting relationships. And finally, leadership and governance, including a supportive policy environment, government support and recognition, coordination and regulation, midwifery education and training, and monitoring and evaluation. So next, we're going to look at the barriers in a bit more detail. The next slide, please. So despite our focus on the factors for success, there of course emerged some barriers to success in implementing midwife-led birthing centres, challenges which can impact their ability to provide high quality care. So I'm going to briefly outline for you the 4 high-level themes which emerged from our case studies in this area. So funding models that reduce affordability. Firstly, some funding models created challenges, both for the women accessing the MLBCs and for the midwives providing the service. Funding challenges were particularly acute for single midwife MLBCs and other for-profits, which had little or no support from government or other organisations. Often, there was no protected or ring-fenced budget for MLBCs, which meant funding was vulnerable to a variety of pressures and competition. Without a ring-fenced budget, MLBCs may have to rely on external funding sources such as NGOs or donations. These can provide great contributions, but can be unpredictable and inconsistent. There is clearly a need for stable sources of funding. For the women accessing care at the MLBC, even where care was free at the point of need, indirect costs could be a challenge and impacted access for some. This included transport, both to the MLBC and also from the MLBC to a referral health facility. It included the cost of obtaining medicines when supplies were not available at the MLBC, and also the cost of food at the facility. A member of staff at Bangladesh told us, many patients are referred, but they do not want to go. They have financial constraints. Next slide, please. So, inadequate infrastructure and equipment. Secondly, some MLBCs suffered from inadequate infrastructure and equipment, which clearly can compromise the safety and the quality of care provided. Some buildings had very limited space to work, and overcrowding could be an issue, impacting the ability of the midwives to provide care and the privacy of the clients. We found some MLBCs lacked even basic infrastructure, including beds, reliable electricity, running water, and toilets. MLBCs lacked equipment such as ultrasounds, and supplies of medicines and other equipment could be unreliable. Geographical inaccessibility was a challenge across the different study sites. There were often poor roads and large distances between health facilities. A lack of organised transport sometimes led to delays in reaching the MLBC or in transferring to referral facilities when required, with all the associated risks to delay. A member of staff from Uganda told us, "We have bad roads. Sometimes a mother says, we fell off the motorcycle 10 times. They are not joking. It's real." Next slide, please. Limited support to the MLBC midwives. We also found that midwives at MLBCs do not always receive the support they need to provide high quality care. Sometimes too few midwives working at a facility produces pressure on those who are providing care. This situation is often exacerbated by low salaries for midwives or unreliable payment of salaries, which do not reward the midwives for their role and make it more difficult to attract and retain midwives at the MLBCs. Some midwives found that they were not respected professionally, particularly by other medical staff at referral facilities. And midwives were also concerned that they were overlooked for in-service training and that they lacked opportunities to ensure that they were prepared to deal with complications and emergencies. A lack of guidelines specific to midwife-led care also contributed to midwives lacking confidence. A member of staff in South Africa told us the biggest challenge is finding good referral doctors and people who respect what we do. I can't read that. That they are open to it and respect our patient's choice to not choose them to start off with. Thank you. Next slide. So, lack of integration into the health system. Lastly, some MLBCs were not well integrated into the health system of the country. If there is limited governmental support for MLBCs, it limits their ability to collaborate with other healthcare providers or to access training and educational opportunities, which, as we've mentioned, is an important support for midwives in MLBCs. Referral mechanisms were sometimes based on informal relationships made between specific healthcare workers and can be fragile. If there is no formally agreed referral system, this can put both the midwife and the client in a vulnerable position should emergency care be needed. Where MLBCs were not well integrated into the health system, they also lacked regulatory oversight within that system, potentially impacting the quality of care provided, as well as having poor monitoring systems. So a leader in Pakistan told us, "So unfortunately, the introduction of community midwives and midwives is good on the ground level, but somehow connecting them to the basic health unit, connecting them to secondary units, and then how to go from secondary to tertiary unit, it is all loose." So these were the main areas of challenges to success for the MLBCs that we found. They need recognition and attention in order to produce a more conducive environment for the flourishing of MLBCs, and so that they can provide the very best care to the women they serve. So now I'm going to pass over to Mandy, who's going to talk about an aspirational MLBC definition. Mandy.
Thank you, Kirsty. Thanks very much. So next slide, please, Bruna. So we had to rethink the definition of an MLBC on the evidence that we found, and we wanted a definition that addresses who the care is for, who provides the care, what care is provided, and how and where is the care provided. And the important element is that care is provided according to a midwifery philosophy and model of care that centres the woman as a decision maker and the midwife as bringing professional knowledge and expertise. Next slide, please. When we think about who the care is for, care is provided primarily to women and their babies across the continuum of pregnancy, labour and birth and the postnatal period. Antenatal care immediate postnatal care, including newborn care and sexual and reproductive health, may be provided. The important thing is that the focus of care needs to be individualized, culturally sensitive, and adapted to suit the settings and needs. Next one, please. So we needed to think about who the care is for. Well, care is provided for women and newborns at low risk of complications. So primarily, MLBCs provide care to healthy women who have low risk of pregnancy-related complications. However, referral to a different model of care at a secondary or tertiary level may be required. And it may be useful, as Kirsty has already highlighted, to develop level of care criteria supported with referral criteria and clinical management guidelines to ensure that every woman can access the level of care she requires at an appropriate location. And lastly, who provides the care? Well, midwives are the lead professionals. These should be midwives working to their full scope of practice within their national legal framework that take primary professional responsibility for the quality of care provided at MLBCs. Now, their scope of practice includes training in obstetric emergencies and neonatal resuscitation and referral when required. Other healthcare providers may work in the MLBC and be part of the wider team. And if this is the case, the midwives have a role in training and supporting this wider team, including medical staff, nurses, community health workers and volunteers, to ensure that care is based on the midwifery philosophy of care. So how is the care provided? I've mentioned a couple of times that care is provided according to a midwifery philosophy and model of care. Midwifery philosophy and model of care centres the woman as a decision maker and the midwife as bringing professional knowledge and expertise. Care is individualised and provided in partnership, which means that the decisions are made by the woman, informed and supported by the midwife. And within this model of care, cultural safety is embedded into the concept of the midwifery philosophy and in a partnership model where the midwife provides care to meet the individual needs of the person. So I can come to our revised definition. I'll read it to you. A midwife-led birthing centre is a dedicated space, either within or separate from a high-level health facility, where care is provided for pregnant women and newborns at low risk of complications. MLBCs must be integrated into the local healthcare services. Next one, please. As a minimum, MLBCs provide care during labour and birth, but may also provide antenatal, immediate postpartum care, and sexual and reproductive health care. Midwives working within their scope of practice are the lead professionals, and they work according to the midwifery philosophy and model of care. This philosophy views labour and birth as a physiological process and takes a woman-centred, rights-based approach to the provision of respectful, culturally sensitive, personalised, competent care, and encouraging the participation of the birthing woman's partner, family, and community. Sorry, I've got my chat box over what I'm trying to read to you. MLBCs consult with and arrange referral to other health facilities or services when required. So this definition is very similar to others, notably the work of Jennifer Stevens and colleagues within the Good Birth Network. And this is really encouraging, especially because we reach similar conclusions using quite different methods and approaches. And in turn, this provides validation that our conclusions are sound and applicable in a wide range of contexts, including low and middle income countries. Professor Caroline Homer is now going to talk us through the pathway to change to support the scaling up of MLBCs. Over to you, Caroline.
Thank you so much, Mandy, and a warm welcome to you all joining us for this, our last webinar. And just to reiterate from Mandy, we're really grateful to the amount of work that preceded our study. Jennifer Stevens is one, the work for the Lancet series on midwifery, the work for State of the World's midwifery. Many colleagues have done work that has supported what we've done here. And we hope that the work that we're presenting here will be helpful to you. And maybe another little bit of information that can help you think about supporting scaling up midwifery in your own countries. We know that the definition that Mandy has just presented is what we call aspirational, and it's what we would love every woman in the world to have access to. We are realists as well, and we know that for many of you, this is really difficult. And I really want to acknowledge all of you who work in very difficult environments and very challenging places, and especially those of you who work in humanitarian settings or in areas of conflict. We know this is hard, but maybe some elements of the MLBCs you can take away and think about. So you've seen this slide before in earlier sessions, and this is what makes an MLBC work. And there are 4 key areas, and we keep talking about them and repeating them, and that's because it's important. So leadership and governance, the supportive policy context, regulations, laws, and protocols that define and support midwife-led care and midwife leadership. This is so important. And we've heard from you over the last 5 weeks, 6 weeks, that this is not always in place in your countries, but it's critical to make an MLBC work. The second point is about an effective and sustainable financing model. And Kirsty again this evening has talked about this as a strength and as a barrier. It's a barrier if we don't have the right financing. If women aren't able to access care, they're not able to afford it. So it's really important, if you're thinking about designing an MLBC, to think about your financing model. Because only if you have an effective and sustainable financing model that assures access to affordable, high-quality care at the MLBC will it work. So our third point is really important because it's about the care that the midwives provide. Quality midwifery care that is recognised by the community, provided by midwives who are educated to global standards, who use the philosophy of care, who work in a team, have access to continuing professional development and organisational support. So it's not enough just to train a midwife and put her out in a health centre and hope that she can deliver quality care. She needs all the other things. She needs to be able to practice in a midwifery philosophy of care. She needs a team around her. She needs access to ongoing education, and she needs supportive management and leadership. And we've talked to you earlier in the webinar series about the importance of the community. So if the community really recognises the value of the midwives and the MLBC, they're much more likely to be successful. So again, when we think about implementing MLBCs, strongly encourage you to work with your community. to go and work with the women, with the consumers of your services, to make sure that what you're designing is what they want, to make sure that what you're designing is what they're going to come to. So really important to work with your community. And finally, interdisciplinary and interfaculty trust and collaboration. The MLBC is integrated within and supported by the wider health system, with access to consultation and referral. And we know this is really important. And again, you can't just put the midwife out in the health centre and hope for the best. She has to be integrated within the system. She has to have access to consultation and referral. She needs a telephone that works. She needs an ambulance or a vehicle or petrol to put in the vehicle to get to the next level of care if she needs it. So these 4 elements are what makes midwifery-led birth centres work. And this is what makes up an enabling environment. We need more than just midwives. We need all of these pieces of the puzzle. And at the bottom, you can see monitoring, evaluation, and learning. And again, this is really important that we're constantly monitoring what we do, we're evaluating the service we provide, and we're learning. We're learning what works, we're learning what doesn't work, and we're brave enough to change it, because that's a learning environment that we have to have for our MLBCs to really function. I'll go to the next slide. Thank you, Bruna. So the next few slides are some things that you might like to take in your planning. And these are kind of suggestions for how you might start if you haven't started, or if you have started, maybe have a look at these issues and see whether you're doing as best as you can, because that monitoring, that evaluation, and that learning is so important. So in the first one, leadership and governance, analyze your context setting, your policy environment, and your financing models. Ensure that the strategies are developed that are going to maximize successful implementation. We need to set up to be successful. We need high-level leadership at government and health service level, and that includes local midwifery leadership and your professional associations. So those midwife associations in each of your countries are so important. Work with them. They're going to be your supporters. And then the midwifery regulatory framework, ensure that that enables midwives to work to their full scope of practice. We need midwives to be able to do all the things that are in the ICM competencies. We need to make sure they can work to their full scope of practice. So that's the first one. The second one, the suggestions are in terms of financing. And again, assessing the elements of your enabling environment and thinking ahead, develop and implement an action plan. What do you need to get in place? And then working out your financing. So you have to have adequate financing to have enough staff to provide respectful maternity care. If you can't afford the MLBC, maybe you shouldn't set one up at the moment until you have all those things in place, because you really don't want to set it up and women can't attend because they can't afford it. So the next area is about quality midwifery care is provided and recognised by the community. And I've mentioned this already. It's really important to ensure the community is informed and engaged at every level to facilitate trust, ownership, and support. We also have to involve all relevant people. So I've mentioned the relevant people in the community, but we also have in some of your countries women's groups. There'll be health service managers that are really important. These are a key group of people. They may not be midwives, so we have to help them understand MLBCs. And then, of course, obstetricians and pediatricians. You need to have a space where your MLBC can be. A space that is accessible, welcoming, has space for women to move around and have a birth companion. This may not be a separate building or anything separate from your maternity unit. It may be within your maternity unit, but it has to be an identified space that women know to come to, and that can be called the MLBC. We have to recognise and value the unique contributions of midwives and promote a culture of mutual respect and trust. We have to design the model of care. And remember, some of the models we have looked at were only for labour and birth, but we're suggesting in our definition and in the work that it could be broader than that. Could be antenatal, labour, birth, postnatal, and maybe also sexual and reproductive health care. So design your model of care within a midwifery philosophy based on your policy and your financing. You have to recruit, deploy, and pay midwives who have been educated to hold the global competencies and can provide care to women and babies across the continuum, including in collaboration with doctors when complications arrive. And finally, really important to make sure your midwives have access to CPD, continuing professional development. They have professional support and they have financial resources to ensure access. Now, when I look at this list, it's a bit of a scary list, actually, because in many countries, I think it will be difficult to have everything on this list. So you may not be able to have everything on the list, but it's worth thinking about what you can have. What's feasible in your country now, and what might be feasible in the future? What might be your 3-year plan, your 5-year plan, your 10-year plan? And that you may not have everything on this list now, but I think you shouldn't let that stop you from starting something. We go to the next slide. Sorry, Bruno. And finally, the last couple, interdisciplinary, interfacility trust and collaboration. This is where we develop and implement criteria for access to the MLBC. We have the systems of consultation and referral. We also must ensure equitable access to transportation for effective and timely referral. And these are very important to make sure that the MLBC is integrated into the wider health system. So under monitoring, evaluation, and learning, we have to build these in. So build in monitoring, evaluation, and lessons learned to ensure quality improvement. We have to have what we call core health outcome measures and routine data collection to allow monitoring and evaluation over time to drive quality improvement. This dot point we actually don't have at the moment, and it is a project that needs to happen. And if anybody is out there looking for a research project, this is a great one. We need to develop core outcome measures for MLBCs. And that goes to the next dot point as well about standardized cost data and data sharing to be able to benchmark across the services and the shared learning. And we heard about this in our last webinar when we talked about costing with Vanessa Scarf and Emily Callender. And the really important bit about the same cost data being collected. So again, another really good project for somebody. And we need to encourage participation in interdisciplinary research and quality improvement. And many of you are doing this already, and you're sharing this with us in the chat, and that's fantastic. Thank you. So I'm going to show you what we call a pathway to change. You've seen these 4 boxes already, the 4 things that make MLBCs work within an enabling environment, within the monitoring, evaluation, and learning. And Bruna, if you click the next button, we should see what we hope this will do. So if you have those 6 things, we think that you will get greater access to sustainable MLBCs offering affordable, high quality, respectful care. Women will be able to come to MLBCs. And secondly, MLBCs will be embedded within functional networks of care that purposefully interconnect service delivery points to create continuity of care. And you might remember in our very first webinar, we talked about networks of care. And one of our papers that we've shared with you is about networks of care. So the way pathways work, if we think about what makes the MLBC work, then we think about what will it lead to in the medium term, and then what will it lead to in the longer term. And these are 4 things that we think it will lead to. The first one is about positive childbirth experience and high quality, respectful care. The second one is about trust and positive relationships between women and families and community and the health system. The third one is about improved things like prevention, recognition of complications, referrals, documentation, and data. And the last one is about increased respect for midwifery, for the work that we do, for our philosophy of care, and will make us more satisfied with our work. So we'll go to the last one now. Thank you, Bruna. Okay, so again, going across, we have these 6 things that makes them work. We have some medium-term outcomes. We have some longer-term outcomes. And then we have the impact. And this is what we really want to get to. We want improved maternal health. We need improved newborn health. We need improved women's experience with care and improved mental health. And we need reduced burnout for midwives and increased satisfaction and retention of midwives. So this is our pathway to change. Some of it we know will happen because we have evidence from our study and from other studies, but there is always more research that needs to be done, particularly when we want MLBCs to be at scale. And by that, I mean not just one MLBC for 100 women a year or 200 women a year. I mean MLBCs for all the women in your country, or 80% of the women in your country. So we need more research about how to scale it up. And you're the people who are going to do the scaling up. And I really encourage you to do the monitoring, the evaluation, and the learning. Let's go to the last slide, I think. All right, so some final points. To be successful, you need to focus on women and the community. You need to focus on the midwives who will provide the care. You need to have a positive policy context. You need to have financial models that work, that are implemented, accessible, and relevant. And you need integration with the wider health system. In our 16 MLBCs that we studied, there was not one that was exactly the same as the other one. So there is not one size that fits all. Your MLBC must fit your context and your situation. And you need to build on what you already have. So some of you have MLBCs already, or some of you have antenatal clinics, or you might have a service where you have midwives providing care in a labour ward or a birth centre. Work with what you have, build with what you have. And don't let perfection be the enemy of good. So don't wait until you have all the things on every one of our slides, because that will be a very long time for all of us in all of our countries, my country in Australia, just as much. So we encourage you to get started, to learn from what you do, to make changes, and to try again. And that learning is so important. So I'm going to stop there and say a big thank you to everyone. I want to recognise my colleagues from the countries, and you've heard from them over the last 6 weeks as well. So our colleagues, I know we have colleagues online from Uganda, from Bangladesh, from South Africa, from Pakistan, and our colleagues from the University of Technology, Sydney as well, who are here. And I really want to thank everybody who's been part of this, especially Andrea Nove from Novometrics, who you met in the first webinar, who's provided just exceptional leadership to make this project happen. And of course, we thank ICM who've been wonderful in making this project happen. And finally, to thank the Bill and Melinda Gates Foundation, who provided the funding to enable us to do this study. And we're super happy to have been able to bring it to you in these webinars. So I might go to the last slide, the Q&A, and then we could probably come off the, Mandy I'm going to hand over to, who's going to do the Q&A from ICM. Thanks, everybody.
Thank you so much, Caroline. And just to echo your thanks to everybody, ICM is delighted to have been part of this. And thanks so much to yourself and to Andrea for exceptional leadership and the ability to participate in such a wonderful piece of work. So we have a few questions, and I think the first one is quite an interesting one, thanking us for our informative presentation. So I'm glad that it's been useful for you, and talking about what sort of level of education do midwives need to work in midwifery-led care. So the example given to me is by Julia Irani from Pakistan. There are many cadres of midwifery. So what level of education is needed for midwife-led care? Caroline, you're an educationist, so can I pass that to you?
Yeah, look, I think in an ideal world, we say that midwives should be educated to global standards. So that means a direct entry midwife has a 3-year program as a minimum, and a midwife becoming a midwife after being a nurse has an 18-month program. The reality is that's not everywhere in the world. And so I think you take what you've got and the midwives that you have in your country, and many of them will be 2-year trained midwives, and you work with what you have. Because really, if we all wait till we've all got the perfect number of cadre, the perfect type, we will never do anything, to be honest. So I think go with what you've got, really support your midwives. Like maybe they need a little bit extra support. Maybe they need some extra CPD. But we know that in some of our case studies, we had midwives who have had 2-year training or are called associate midwives in their countries. And I think we have to start somewhere. So that would be my thoughts, Mandy.
Yeah, no, I totally agree. I think, working to ICM standards is aspirational, and countries are certainly getting there. We've also got a comment more than a question. Well, I suppose it is a question. Is there any training regulations for this so midwives will be guided? And I'm sort of thinking, are you meaning guidelines for the birth centres themselves? And there are guidelines in some countries, but nothing sort of generic as yet from anywhere like ICM. I think we've mentioned several times throughout the series, sorry, I've just realised, interpreters, I'm speaking quickly. We've had comments throughout the series, and we've let you know throughout the series that WHO are indeed working on some information around midwife-led care. And what has come across really strongly to us as the team working on this is that some more practical information would be really helpful. And talking about that, Rondi Anderson made a really interesting comment, actually, 2 comments that were really interesting. Firstly, about UNFPA's work in Syria, where units called normal birth centres have been set up to support women in a really fragile situation to receive maternity care. And although some of them aren't functioning, many are, and they are being strengthened. So there's an example of how midwife-led birth centres can function in countries that really are going through humanitarian crises. And Rondi made a very valid point. She said, I'm noting that you do not have support to implementation on the ground as part of what makes things work. Research alone won't change things, and it's implementation support that's needed. And this is also the WHO Quality Maternity Network referenced on-site support. So do we have any different experience or research? My comment to that is that, we would really quite like to be able to provide you with an implementation toolkit that's under discussion at the moment. But Andrea and Caroline, I wonder if there's anything that you'd like to comment on around, and indeed Kirsty or Oliver, anything that you'd like to comment on around, what do we do with research once we've landed it? What do people do?
Yeah, I mean, I think it's a great comment, Rondi. Thank you, and really acknowledge your very deep expertise in this area. I guess probably why it didn't come out in our study is that the MLBCs were all established, and they were selected because they were all established. They weren't being established. And so maybe that's why it didn't come out as strongly as perhaps it should have. I will say, though, as Mandy says, the work we're doing with the World Health Organization on the implementation guidance is going to give exactly that. So it's really going to focus on what is the implementation support needed, and there's a whole chapter on what to do to get started, and then how to, I know in Bangladesh, for example, there's been all that fantastic mentoring of the new midwives in Cox's Bazar and other parts of the country. So that's important. It didn't come out hugely strongly in the study, I think, because, as I said, they were all established rather than getting established. But it's a really good point. Thanks, Mandy.
Thank you. And actually, going on from that, we've got several questions coming up about, could ICM share the ICM guidelines to start with MLUs? And I think we've just explained that we actually don't have any yet. And is there a network or platform for midwives who are setting up an MLBU to connect and learn from each other? And that's a request that we've had many times throughout our series as well. So again, nothing definite yet. But what we are doing once we've completed this webinar, we're looking at all the questions that you've asked us throughout the 5 webinars, and we're going to collate a frequently asked question document so that the questions that you've asked really frequently, we will do our best. We will do our best to answer. I think the other interesting thing that's come up, colleagues, panelist colleagues, is the comments around, we work in centres, but they're not necessarily, and the midwives are there, but it's not with the midwifery philosophy of care. There's still quite a lot of medicalisation. So we're getting comments like that. I'm just reviewing some of the others. So this was a really interesting comment from Indonesia, for example. They have what is called a midwife-led birthing centre, but it doesn't necessarily support the midwifery model of care. And midwives have been struggling for a long time in order to provide quality of care, building trust and partnership. As the system is partially supportive, but most of the time they're just working in a medicalized environment, and we really hear that, and we really do understand that that is what is happening in your countries, and we hope that somehow what we've been presenting throughout this series will help you work on with that. And again, a comment that, local government units should be orientated. So again, I think in the last series, we talked about advocacy and advocacy tools to support you, to lobby and canvass your governments and your ministries of health to make these changes. And Caroline, in her presentation, gave us a really thorough overview of steps that you can take. I think as a closing remark, we have a few minutes left. Sustainability has come up, and how to make these units sustainable. And I think we've been showing quite strongly throughout the series, especially last week and today, that it's funding and commitment from governments that are important. And access in rural settings has come up as a theme as well. And I think, again, we've had some really good examples of how in rural settings, midwife-led birth centres can really add value to women who are in uncertain areas and in remote areas as well. So has anybody got any closing comments from our presentation team?
Mandy, I'll just explain to colleagues about the WHO stage work,
Yes,
just very briefly.
Thank you, good idea, thank you.
So at the moment, we've just developed a document that we're calling the what and why. So what is midwifery models of care, and why should you have them? So this is the sort of document that you can use for advocacy. It's the what and the why around models of care, and that includes MLBCs. And we hope that will be available early next year. We're just finalizing it at the moment. Then the next bit is we're developing, we call the how. So the how is, how do you do it? And that's the implementation guidance. And I think the how will answer lots of your questions. So we hope that will be released by May, hopefully. It's still being worked on, so it might be a little bit later, but please, ICM will be part of that launch. So keep following ICM and we can make sure you all hear about it. But yeah, that's my last thing. Maybe Andrea wants to say something to finish, but thank you everyone very much. It's been fantastic.
Yes, really just want to echo Caroline's thanks. We're all mixed emotions here because this has been quite a big part of our lives for the last 2 years, and it's been a really rewarding project to be part of. So just want to acknowledge really all of the team members from all of the countries. I see many of them are saying hello in the chat box, so it's good to see you all. And to reiterate what Mandy said earlier, this isn't the end. It's the end of this particular series of webinars, but we are very conscious that there is demand there for further resources and guidance, and we'll be working very hard to try and make some of that happen in the coming weeks and months. So we'll try and keep you informed on that. Thank you.
Thank you everybody. Thank you to all our attendees today, 240 of you, which is delightful, and have a lovely afternoon, evening, night, and thank you to all my colleagues on the panel.
Thank you. Thanks everyone.
Thanks.
Thank you, bye.